Thank you for the opportunity to participate in GIE's author interview series. My name is Neel Choksi, and I'm a recent graduate of the University of Michigan Gastroenterology Fellowship Program. Today, I have the great pleasure of offering some additional insight into our study, the risk of post-ERCP pancreatitis, and the protective effect of rectal indomethacin in cases of attempted but failed pancreatic stent placement. Pancreatic stent placement is widely regarded as an effective method of preventing post-ERCP pancreatitis in high-risk patients. Randomized controlled trial data have demonstrated that not only does a pancreatic stent reduce the incidence of post-ERCP pancreatitis, it virtually eliminates the risk of a severe pancreatitis. Unfortunately, there is a dearth of data regarding the consequences of an attempted but failed pancreatic stent. Prior to this study, our entire understanding of the consequences of a failed pancreatic stent was based on expert opinion and a single observational study consisting of 3 outcome events. To better understand this phenomenon, we conducted a post hoc analysis on a recently published large-scale multicenter RCT, which showed that rectal indomethacin reduced the risk of post-ERCP pancreatitis in high-risk patients. In the original study, more than 80% of patients underwent a pancreatic stent placement. Of the remaining patients that did not, a subset underwent an attempted but failed pancreatic stent. We utilized these RCT data to 1. Determine the incidence of post-ERCP pancreatitis in high-risk patients complicated by failed pancreatic stent, 2. Assess the prophylactic effects of indomethacin on failed pancreatic stent placement, and 3. Perform an exploratory evaluation of risk factors, both clinical and procedural, associated with a failed pancreatic stent. We included all RCT subjects at 2 separate study sites, University of Michigan and Indiana University, which comprised 96% of the total enrollment. We then identified the subset of patients within the RCT who did not have placement of a pancreatic stent. We manually reviewed the procedure reports for all of these patients to determine whether or not an attempt had been made to place a pancreatic stent. A subject was deemed to have experienced failed pancreatic stent if 1 or more of the following criteria were present in the report. 1. Pancreatic stent attempt was made, however unsuccessful. 2. Pancreatic ductal cannulation could not be achieved despite attempts. 3. There was failed cannulation of both the bile duct and the pancreatic duct. 4. Pancreatic duct cannulation was achieved, but the wire was lost prior to stent placement. And 5. Pancreatic duct cannulation was achieved, but the ERCP was aborted prior to completion of the procedure. A total of 577 patients were included in the analysis, with 42, or 7.3%, determined to have experienced a failed attempt at pancreatic stent. 77 of the 577 patients in the analysis, or 13.3%, experienced a post-ERCP pancreatitis. 51 of these patients, or 17.3%, were in the placebo group, and 26, or 9.2%, were in the indomethacin group. Of the 294 randomized controlled trial subjects that were randomized to receive placebo, 23, or 7.8%, experienced a failed pancreatic stent placement. 8 out of these 23 patients, 35%, developed a post-ERCP pancreatitis. This is higher than the rate of pancreatitis among the 238 patients that had successful pancreatic stent placement, 16.4%. It is also higher than the rate in the high-risk cases where no attempt at pancreatic stent placement was made, which was 12.1%. Of the 283 patients that were randomized to receive indomethacin, 19, or 6.7%, experienced a failed pancreatic stent placement. Only 1 of the 19 patients, 5.3%, developed a post-ERCP pancreatitis. This rate is similar to the post-ERCP pancreatitis rate in indomethacin patients who were successfully stented, 9.6%, and the indomethacin patients in whom no attempt at pancreatic stent placement was made, 10.3%. These findings show that the increased risk of post-ERCP pancreatitis associated with attempted but failed pancreatic stent placement is reduced by prophylactic indomethacin. Exploratory risk factor analysis also revealed that increasing age, a history of recurrent pancreatitis, and difficult cannulation are all independently associated with a failed pancreatic stent placement. To summarize these results, patients who experienced a failed pancreatic stent are at approximately threefold higher risk of developing post-ERCP pancreatitis. Prophylactic rectal indomethacin appears to attenuate this risk. We do acknowledge several limitations in our study. First, failed pancreatic stent placement was not prospectively recorded in the original RCT. Rather, the endpoint was adjudicated in a post hoc fashion by manual review of procedure reports. As such, failed pancreatic stent placement may have been undercaptured if not explicitly documented in the procedure reports, or misinterpreted at the time of review of the procedure reports. Additionally, the event rate in this study was small, leading to possible regression model overfitting and missed associations due to low statistical power. In conclusion, this is the largest, most methodologically rigorous study to focus on the phenomenon of failed pancreatic stent. It underscores the importance of adequate training and proficiency prior to attempting to place a pancreatic stent. It also advocates for the routine use of rectal indomethacin in high-risk ERCP cases. To better understand this problem, future studies should focus on a standardized prospective definition of failed stent placement. I would like to extend a heartfelt thanks to all of my co-authors on this paper, and thank you again to Gastrointestinal Endoscopy for the opportunity to participate in the author interview series.